Enterococci, particularly vancomycin-resistant enterococci, are very difficult organisms to treat, and they tend to affect the most vulnerable patients, particularly those with cancer, immunocompromised, transplant, etc. And as it happens, they are one of the most difficult organisms to deal with. In absence of good, robust clinical data, we are left with, very basic clinical and microbiology sporadic data to be able to treat these organisms. We are going to discuss today some therapeutic approaches and the basis for that in our podcast. The objectives is to review the clinical challenges posed by enterococcal infections, understand the mechanistic basis of resistance with clinical implications in these organisms, and then discuss some therapeutic strategies on how to treat these bugs. Welcome to Editors in Conversations. This episode is brought to you by the Antimicrobial Agents and Chemotherapy Journal, available at aac.asm.org. I'm your host, Cesar Arias, Editor-in-Chief of Antimicrobial Agents and Chemotherapy, and this podcast is supported by the American Society for Microbiology, which publishes AAC. Don't forget to check our really outstanding latest issue of AAC, available at aac.asm.org, with really important and outstanding papers on resistance, susceptibility testing, pharmacology of antimicrobial agents, epidemiology, and clinical therapeutics, among other interesting science being published in AAC. So today we have very special guests to help us understand the treatment of resistant enterococcal infection. And I'm very happy and pleased to introduce Dr. Kerry LaPlante, who is professor and chair of pharmacy practice at the University of Rhode Island in Kingston, Rhode Island, and Dr. William Miller, assistant professor of medicine and the Division of Infectious Diseases at the University of Texas Health Science Center in Houston, Texas. Welcome to the program.
Thank you.
Thank you so much.
You're very welcome. So thank you for taking the opportunity to be in the show. We're going to talk about these bugs that I have a particular interest, and I've probably been more than 25 years knowing about Enterococci. So they are very close to my heart. So this is a very important topic. It's a very hot topic that I think is worth discussing. So I'm going to start with Will, Dr. Miller. So tell us some of the clinical challenges that enterococci pose to us in the 21st century now.
So thank you so much for having us on. I'm really excited to be here to talk about enterococci as well. I think there's a variety of different challenges that we face with enterococcal infections. And really, it can be boiled down to two major points that deal with both the patients that these bacteria infect and then the bacteria themselves. As you stated earlier, these tend to affect those patient populations that are very, very vulnerable to having complications from infection, and really in having those comorbidities that make them a very challenging patient population to treat. So that's going to be our patients who are in the intensive care unit. As you mentioned, our cancer patients, those getting chemotherapy or immunosuppressed because of transplant. And if you look at enterococci in total, with some of the more recent data, when you look at kind of the whole genus, they're actually one of the second leading causes of healthcare-associated infections. And they really are a challenge to us from that standpoint, because we're trying to deal with these in some of our sickest patients. That's going to affect which drugs we're able to select, and we're going to have to worry about things like renal function and how we're dosing these antibiotics. The second goes along with the bacteria themselves. And so enterococci are very durable organisms, and they have a lot of resistance, both what we call intrinsic resistance, or just the resistance in and of itself because of the way the bacteria metabolize and build their cell wall. And they also have acquired resistance. So they're able to take up exogenous genes, incorporate that into their genome, and then express those resistance phenotypes as well. So when you kind of put those two together, we're really at a crossroads where we have a lot of challenges when it comes to treating these infections.
So thank you, Will, for that. My old mentor, Dr. Barbara Murray, always said that in response to comments, I remember Dr. Chip Chambers saying one day that enterococci are the best colonizers of the blood. really referring to the low pathogenic potential of these organisms. But Dr. Murray always said, how do you make a sort of a low virulent organisms a first-class pathogen? Well, give them a lot of antibiotic-resistant determinants. So Kerry, so why are these bugs so difficult to treat?
Yeah, it's a great question. I really think it comes down to two things: resistance and tolerance. So, first, resistance. Enterococcus species, they're intrinsically resistant to the cephalosporin class, to clindamycin, to the semi-synthetic penicillins. And when I say that, I mean our nafcillin, our oxacillin. And also we have acquired resistance with aminoglycosides and even vancomycin. And I think, as most of the audience know, Enterococcus faecium is intrinsically more resistant to the antibiotics than faecalis, and with more than half of its pathogenic isolates expressing resistance to vanco and amp. And we're also seeing high-level aminoglycoside resistance, referring to faecium. So when I speak to tolerance, I think, in my opinion, it's even more concerning, because when you have resistance, you can get your MICs, you know if it's resistant, you know if it's susceptible. But where we see tolerance with Enterococci, meaning that these bacteria withstand or slow down lethal doses of high amounts of antibiotics. So I always think of daptomycin is, I think, the first great example, at least in my experience, is that we traditionally would dose, and daptomycin was approved 6 milligrams per kilogram. But when it comes to treating any enterococcal infections, we see that we need higher doses, such as 10, sometimes 12 milligrams per kilogram, to get the same bactericidal effect. So at the end of the day, we see a lot of intrinsic resistance. We've seen resistance develop throughout the years. But again, what scares me most is the tolerance with these antibiotics.
Yeah, so the concept of tolerance is actually a very interesting one and a bit murky from the scientific point of view. When you go to the spectrum of resistance to tolerance and persistence, there is a lot of debate exactly where one starts and the other finishes. Because at the end of the day, there are a lot of in vitro phenotypes that may or may not work there. So that's a very interesting topic. But Will, one of the things that Enterococci are commensals of the intestinal tract, and I think we've had a very interesting relatively recent genomic data to try to understand how these things evolved. Can you mention some of these characteristics that help these organisms becoming from a commensal to maybe a intrahospital pathogen?
Yeah, so you mentioned, they're good bloodstream colonizers, kind of, it's kind of the funny thing there, but they are actually really good GI colonizers as well. They've kind of grown up with adaptations to the GI tract. So when you look at the genomics, they can actually trace back using molecular clocks the potential for these organisms to kind of have migrated, their ancient ancestors to have migrated with terrestrial land animals onto the surface of the land, and then to deal with the new environment and the potential for being exposed to, drying out and heat and things like that. They've really kind of adapted to these environments and to this niche in the GI tract. And so that has implications for us, even through today. So some of those risk factors we know of for acquiring VRE, really are going to be related to those exposures to broad spectrum antibiotics like the cephalosporins, to which they have kind of this intrinsic tolerance and resistance. And therefore, you're going to kind of knock out some of the regular GI flora, and you're going to end up with, the Enterococci being left to kind of overgrow and dominate into the gastrointestinal tract. They also have a variety of different systems to deal with the host as well. And this goes back to dealing with those host antimicrobial peptides that are expressed in the gut, as well as antimicrobial peptides that may be made by other gut microorganisms. And so there's kind of a really fascinating interplay and interaction here that goes back to what we call colonization resistance of the host, or the microbiome and the innate immune response that serves to keep some of these populations in check. And so we know as people get exposed to antibiotics, as we have them get critical illness, end up in places like the ICU, and we stop enteral feedings and things like that, that throws this whole kind of consortium out of balance. And we get this, expansion in the Enterococci to where they can even dominate, where we see them at over 90% of the GI tract. And then from there, there's been some, really elegant work by Eric Paymer's group about how these then can go on to become bloodstream infecting isolates and cause disease from there. So I really think that, from that aspect, their colonization of the GI tract, and then their potential translocation and ability to cause disease. That's what makes it one of the really challenging aspects to treat. And then that has these other implications too when we start talking about daptomycin. So it's an antibiotic that in ways mimics some of these host antimicrobial peptides as well. And so exposure and changes there to both the antibiotic and the host immune system have consequences for treatment down the line.
So excellent. Just thinking about, as Kerry mentioned at the beginning, all these drugs that we use, like cephalosporins that concentrate in the GI tract, that really sort of help wipe out any competitors in the gastrointestinal tract, and eventually this concept of domination of that GI tract by these organisms. So clearly, in terms of clinical impact, we have two species that seem to have evolved a little bit different, Fecalis and difficile. And the Fecalis, we think about these species are probably the most equipped in terms of virulence factors, but a little bit more susceptible to antibiotics, although you can argue that that's probably not completely true, and they are also very difficult to treat in certain circumstances, but definitely less vancomycin resistance and all that. So we go back to the experiments of Bob Mullering and how important it was that monotherapy with a beta-lactam, particularly a penicillin, was not as effective as you would do for Streptococci, for example, with rates of cure, for example, in endocarditis that were lower than Streptococci. And from that time, it is being recommended to use the combination therapy, which is particularly the aminoglycoside and the beta-lactam. And there were very nice mechanistic studies suggesting that it's probably the use of this combination, so weakening of the cell wall allows more penetration of the aminoglycoside. So, Kerry, I just want to move forward in time and go to now the approach for Enterococcus fecalis treatment in terms of now instead of doing this combination, which had been shown in some prospective studies to be toxic, to have an alternative combination, which is a dual, not very intuitively, beta-lactam combination for ceftriaxone and ampicillin. So why don't you tell us about where are the bases to choose this combination for fecalis, and how this knowledge evolved with time?
Yeah, I'm happy to. Something I'm very passionate about is combination therapy, because I think sometimes the jury's still out on when do we use combination therapy. And I always refer, like all of us will refer to, does it prevent resistance like we see in HIV and tuberculosis? We don't see those same studies in our, bacterial studies. But I think Enterococcus fecalis kind of really highlights the origins of combination therapy. So as we unpack that, my understanding is it really began with Enterococcus fecalis and infective endocarditis. We know bactericidal agents. We think and I believe that, we see greater in vitro kill in the lab. I have a lab. I like seeing that. It's very satisfying that I can kill and control these organisms. It doesn't always translate to clinical trials because there's so much variability. And as we know, we find these clinical trials and the truth is over here somewhere. We're always trying to do better. But when we unpack the origins of combination therapy, we know that, and you believe and you're on the stance that bactericidal activity is perhaps a good thing, beta-lactam antibiotics lack bactericidal activity alone against most Enterococci. And I'd be interested to hear what you guys see in your labs. But, when you're using monotherapy, we don't see the traditional beta-lactam bactericidal activity, which makes things a little challenging, especially in our more invasive infections and high inocula infections like infective endocarditis. So although fecalis is susceptible to amoxicillin monotherapy, treatment failure is as high as 60-70%, perhaps because of that lack of bactericidal activity and that lack of, with any of the cell wall agents, whether it be penicillin, ampicillin, vancomycin. So originally, penicillin or ampicillin was combined with Gent, just as you said, to facilitate the intracellular uptake of the aminoglycosides. We recognized that synergy. We saw increased cure rates when we had combination therapy from maybe 60% to 75%. So that was good. However, we've been seeing high level aminoglycoside resistance. That continues to increase. We know aminoglycosides are nephrotoxic drugs. We don't love using them. And those early initial in vitro studies by Marinari and colleagues in 1995, they were the first to report that synergy, in vitro synergy between amoxicillin, and it was actually cefotaxime in the earlier years, and Gavalda is who took this a little bit further in 1999 to look at AMP plus ceftriaxone. That proposed mechanism of synergy, which was, the real question here, is what we propose is that there's partial saturation of the essential penicillin binding protein 4/5. Lou Rice is really kind of leaning to its PBP4. And with the amoxicillin, we have this upregulation of penicillin binding protein 2 and 3. And that's where the cephalosporins like cefotaxime and ceftriaxone really have their effect. So now we have optimal inactivation of penicillin binding protein 2, 3, and 4. And perhaps, that's why we propose we see that bactericidal effect. But what does that do in patients? And when we took it to animal studies, how did we see a difference? So if I may, I'll kind of quickly dissect those studies. Do you want me to do that now?
Yes,
yeah.
That's it's fascinating data.
It is. It's good. And, briefly, animal studies we saw that we did the right things. We move forward. There's really 3 big clinical studies, 2 prospective clinical studies. So first, 2007, Gavalda, he and colleagues assessed the efficacy and safety of amoxicillin and ceftriaxone in around 20 patients that had high-level aminoglycoside resistance and around 20 patients that had non-high level aminoglycoside resistance with an infective endocarditis with Enterococcus faecalis. And this was an open label clinical trial. It was an observational study, and basically they showed that amoxicillin and ceftriaxone were a safe and effective treatment option for high level aminoglycoside resistance, especially when we had patients, and these are sick patients, as we mentioned early, that are more at risk for nephrotoxicity. So subsequently, in 2013, Fernandez and colleagues, they also conducted a large non-randomized multi-center cohort study comparing the safety and efficacy of ceftriaxone and gentamicin in a large cohort of around, 250 patients. And again, this was infective endocarditis caused by Enterococcus faecalis. And those authors concluded that the 2 combinations, again, were equally affected. There was no difference in mortality, while on antimicrobial treatment during 3 months following, no difference in relapse or treatment failure. But again, the patients that were treated with the amoxicillin gentamicin combination had significantly higher rates of adverse events. So that leads us to think, well, it's always a conversation of efficacy versus safety in these patients. The third study was really redone by Dr. Fernandez and colleagues. This was more of a prospective in-house study where they went back and looked at 1-year mortality. Again, they didn't see a difference. So at the end of the day, the conversations always land on, is this a safety issue? Do we move forward with the dual beta-lactam combination therapy? What we see in the lab, does it always translate to clinical studies? Or do we go with that tried and true amoxicillin plus gentamicin combination, which I have some colleagues that really kind of prefer to go back to that. So I'd be interested to hear what you guys say and if you have strong opinions.
Well, I did have the opportunity to write the editorial with Dr. Murray on this, and we were actually in opposite sides of the spectrum as you read that. So, and I know there are, opposite side of the spectrum here, and without a a new randomized blinded clinical trial is going to be very difficult to settle. But in my opinion, and this is a very personal opinion, I've used that combination of ceftriaxone and ampicillin. I think it doesn't make sense to put patients at risk of nephrotoxicity, particularly when you have infective endocarditis. And, at least the data support that. What do you think, Dr. Miller? Where is your opinion on this?
No, I have a similar opinion there. I mean, when you kind of look at that balance between the safety and the efficacy, as you said, without a double-blind randomized trial, we won't have the definitive answer. But at least kind of from the data that we do have, the combination, seems to have the efficacy there, and you can spare the toxicity of the immunoglycosides, especially in patients that may have renal issues pre-existing before then. So certainly, it's a combination that I have utilized as well in practice.
So Kerry, what were you going to say?
Yeah, it's obviously passionate about it too, but we can't forget that ceftriaxone with the enterohepatic recirculation, when the drug, just is secreted back in the bile. That's why we have that long half-life with ceftriaxone, can promote VRE, can promote C. diff. So I think it's a trade-off. So I'll talk out of both sides of my mouth here.
Yeah, this is a very good segue for the next question that I had to use. So there are some reports that people have actually called me and try to, the patients that have failed that combination, right, for any other reason. And then these issues that you mentioned, on the use of ceftriaxone on this. So, Kerry, let's go to you. So you wrote about this. So what alternatives we have now for Enterococcus faecalis? Of course, the clinical data are scarce there, but, with the mechanistic and laboratory data and some animal data, so what other alternatives for treatment on these patients do we have right now?
Yeah, the number one question I get, right? And this is why we love ID, is because we don't have a lot of head-to-head comparator trials. It's the pain and the joy of being an ID specialist. So we all know that Enterococcus, it poses a significant challenge. We know that, and please call me out and tell me what you guys think, but for our penicillin-susceptible VREs, like Enterococcus faecium, ampicillin remains the drug of choice, especially if it's not a high inocula, more serious infection. But, for our generalists out there that are listening, important to note that nitrofurantoin, fosfomycin, doxycycline all have activity against enterococci, including VRE if susceptible. And those are potential oral options. Yeah, go ahead. Yeah, please.
Let's focus on faecalis first, and then we will have the rest of the program talking about fission, which, if there's some controversy in faecalis in fission, there will be an enormous controversy. So let's focus on alternative treatments for Enterococcus faecalis, severe infection, endocarditis or bacteremia, the alternatives to the ceftriaxone ampicillin combination.
Yeah, so where I would go down the road, and tell me what you think, is I think another option is daptomycin. So a high dose daptomycin, certainly. I think there's needs to be some delineation of clinical data on the use of omadacycline. I don't know what you guys are thinking, shaking your head, maybe yes. What I can say, for those of you who don't know, omadacycline, it's a derivative of minocycline. So it's a novel tetracycline. It's available as IV and oral, and it does have very low MICs against Enterococcus faecalis and faecium. And those MICs, minimum inhibitory concentrations, are lower than what we see with doxycycline or minocycline. So can I pause and say, reactions to those both comments of daptomycin and omadacycline, what you guys think?
So, Will, dapto alone or dapto with ampicillin?
So this kind of gets into something that we'll talk more about with fission as well. But then when you're looking at faecalis, so when I think about, are we failing that particular therapy with ampicillin or amoxicillin ceftriaxone, first off, I'd be kind of inquiring with my lab and understanding, do we have a documented faecalis or fission as far as which species that we have? I know some labs may use the ampicillin or amoxicillin susceptibility to kind of call one species or the other, because overwhelmingly your Fecalis tends to be ampicillin susceptible, with your Faecium being resistant. I kind of put that out there. There was one study that was in the Journal of Antimicrobial Chemotherapy where they looked at the combination of ampicillin ceftriaxone in Fecalis, and then also in 6 or so species isolates of Faecium as well. And they saw that only about 33% of the Faecium ampicillin susceptible Faecium isolates demonstrated synergy. So I guess the open question there is there some difference between the species, and can we expect that to reliably work as well for Faecium as it does seem to for Fecalis? And then is there other things that are underlying the resistance phenotype there that may impact that? And I think that kind of goes back to, as you were talking about the PBPs. For Faecium, we have the PBP5, which is involved in the resistance for ampicillin. And then you said the PBP4 in Fecalis, which there can be mutations that occur both in the enzyme that affect the active site and then in the promoter and how much is expressed that may impact what exactly your MIC for ampicillin is, and then whether you get this kind of penicillin resistant, ampicillin susceptible phenotype. And then what does that mean with regards to using the combination or not, and everything there. And I think these are all open questions that I think really kind of deserve a look specifically to see how they may kind of impact some of those. So I think that's kind of where I would initially start my thoughts. And then, obviously, if we need to think about a different regimen, I think that daptomycin is certainly one of those. And then I think if you're starting to go with second line therapy for any of these, that's when we have to start thinking about combinations. And we can talk a bit more about this as well, especially in regards to using daptomycin with something like a beta-lactam. And then I think for, infections that, aren't bloodstream infections, like you said, for omadacycline and things like that, using that is certainly an option that may be very helpful, and potentially give someone oral options to be able to take as well. I think when we get to more invasive bloodstream infections and endocarditis, that's when, again, we're talking about kind of going back to the paradigm of needing the combination therapy.
So in summary, I'm saying that, I tend to use the ampicillin ceftriaxone combination in patients that are severely infected, particularly endocarditis or all bloodstream infection. But my alternative therapy is actually daptomycin ampicillin, and we're going to talk about some of those changes. And we won't have time to talk about all what happens at the membrane level when you use daptomycin. But I think all the mechanisms that we know now that alter the cell membrane when you use daptomycin may favor the activity of ampicillin, particularly because we don't really have description of Enterococcus fecalis with high ampicillin resistance or high level of MICs. So I think that combination is useful. What Kerry was telling you about the ceftriaxone and the GI tract, the facility to use once a day, right? For example, for prolonged therapy, I think that's an interesting alternative in those scenarios. And I don't probably want to go down the road on this because we failed both too. There's something wrong here with fecalis. So, okay. This is very good. So let's go to the most complicated, controversial, and lack of data sort of topic, which is Enterococcus faecium, the true sort of particularly vancomycin-resistant Enterococci. With the caveat that the majority of these organisms, particularly faecium, have high ampicillin MICs. So precluding and MICs more than 64, precluding at least the use of monotherapy with ampicillin. We would talk about maybe the combination. That a lot of those also have a lot of aminoglycoside resistance, particularly that bifunctional gentamicin resistance, and I know that other aminoglycosides may be also affected, but. That's the only drug that is really approved right now to treat this organism is linezolid, which is at least in the lab seems to be it's a bacteriostatic drug, protein synthesis inhibitor, with a lot of toxicities if you want to use it in prolonged therapy. So with that, very low optimism statement on how to treat this. let's start discussing in this. So Kerry, what are your initial thoughts when you have a patient with fission with a bad infection, bloodstream or endovascular?
I call you. No. It's tough. These are really tough cases because we see a lot of vancomycin resistance. Usually the conversations play out, and I think for the sake of our audience here, it's important to know there was some excitement when vancomycin came out. So this is a long-acting kind of like a vancomycin-like lipoglycopeptide that has a half-life of 200 to 300 hours, which is 10 days, depending where you look at it. And it possesses activity against vancomycin-resistant Enterococci and MRSA, and it makes it an attractive option for patients with VRE infections when options are limited, and you want to make life easy for your patients, which is why we're all here at the end of the day, and maybe give them one dose or, maybe revisit in a week to 10 days. That's a whole other conversation. It has some safety considerations. Can't use it with unfractionated heparin, has an artificially long APTT time. It's an inducer and an inhibitor of the P450 isoenzyme, but I think it's an option. And I don't mean to keep going back to you guys, but do you guys have any experience using vancomycin for VREs, and what do you guys think?
Yeah, we did, Dr. Miller. So let's go. That this is a very interesting question. What will be your initial approach, and then I guess we go down the list of drugs that we may be able to do that when you have an efficient, let's say, bloodstream infection in a very sick patient.
So I kind of think that first decision point, as you said, is, so kind of which agent do we think about selecting? And the two major ones, as you kind of mentioned, are linezolid or daptomycin. And I think there's been kind of a lot of interest in trying to figure out, which should we select here? And do we have any data that kind of shows us push us in one direction or the other? There were several different meta-analyses. With the caveats that, a lot of the data that we're basing this on, well, it's all, retrospective. We have observational studies and we have heterogeneity of the different endpoints and everything. But really the jury came back kind of mixed. Some showing some favoring of linezolid in some of the earlier meta-analyses, others without showing any real difference. But I think there was a nice observational study that included around 600 patients from the VA that was published in Clinical Infectious Diseases by Britt and colleagues in 2015 that looked at either patients who got linezolid or daptomycin for VRE infections. And there were about 300 who had received either one. And looking at this and kind of controlling for those confounders that they could, they really showed that it looks like daptomycin really has lower mortality and treatment failure as compared to linezolid. And I think then of the follow-up that they did, and this has been demonstrated in other publications as well, is to look at this and say that it really matters what dose of daptomycin that you use. So you had mentioned before that 10 to 12 milligram per kilogram per day if you have normal renal function. And so I think that is really an important thing when you're going to choose daptomycin, is that to make sure that you're dosing it correctly. And we can talk a bit about kind of some of the CLSI breakpoints and things, because a lot of this kind of is involved in some of the recent changes that have been made there. But in the study that they kind of did as a follow-on in 2017, they looked at what they called standard dose therapy. So this is the 6 milligrams per kilogram per day, which is kind of the FDA-approved dose, which was studied in relation to Staph aureus bacteremia. And then a medium dose at 8 milligrams per kilogram per day, and then the high dose, which was 10 or more. And so really kind of at each gradation, you saw an improvement in mortality, with the high dose showing the best overall survival. And then maybe you can talk a little bit about some of the AUC and pharmacokinetics, because I think you're probably a bit better, have a bit more to talk about with that. But really that kind of goes into making sure that you're using the appropriate dose and that you're getting a good one on board. And importantly, from that study, they also looked at the CPKs, the creatinine phosphokinase, so they didn't see any big changes with the high dose there. So it seems like it's something with close monitoring, if you're watching your patients and selecting them appropriately, that it's okay to be using these higher doses. And it really seems to be that those are important for efficacy, especially against Enterococcus faecium.
So that study, and there is one published in our journal, Antimicrobial Agents, from the same group, that showing even the patients you start with linezolid and switch to daptomycin, they still did worse. So that data supports, okay, maybe daptomycin should be first-line therapy. There's also people here at different spectrum, so I don't want to be very dogmatic, but that's what the data showed. So the question now, should you use it alone, Kerry, or should you use it in combination in those that are ampicillin resistant? Particularly, what combination and which drugs will be useful? And then we'll go back to the oritavancin topic.
Yeah, it's such a great question. And what I would say in all of these studies, and I've done similar VA studies, remember I said earlier, the truth is over here somewhere, because we don't know the immune status of the patient. We can't look at all the creatinine clearance, which is changing all the time in these sick patients. We don't know what other medications they're on that are immune compromising, right? We see statins, we see, there's so many other things going on in the patient. We don't know the inoculum. We don't know if it's an endovascular infection. And I know this audience knows that, but it just needs to be said. So I do take those studies with a grain of salt, but certainly applaud the work. So the specific question is regarding combination therapy. As I said before, I'm a fan of it. That's what I've studied for 18 years in my lab. All of my experience is pretty much in vitro. But when I look at daptomycin in combination with ampicillin, or even ampicillin in combination with carbapenems or penicillin, or really anywhere else we've looked, the sad news for this audience is it's very strain specific. I get really excited and we'll look at like 3 strains in a row with time kill studies, and we see great synergy, and then we see indifference or sometimes antagonism. And for those of us who are doing in vitro work, we know that. How are you defining that synergy? Checkerboard isn't enough. Is time kill good? Is it in vitro flow model where I'm modeling the PKPD and the AUC? I hate to, put a wet blanket on this, but there's so many things that we can never control for and never really get to our answer.
So we due to that lack of data, we had several studies with Dr. Ryback in his subendocardial vegetation model, which initially showed actually ampicillin, maybe ertapenem, and ceftolozane were useful. But when we actually started testing strains that have mutations that we had described, and we know the conduct resistance, the one that uniformly seemed to respond better was the combination with ampicillin, whereas the ceftolozane and ertapenem seem to be more strain specific, as you initially mentioned. So if I were to use that combination, that would be my first line combination. And Dr. Miller, what do you think about it?
Yeah, so I think that certainly for combination therapy, the daptomycin plus a beta-lactam, and as yourself, I would favor using ampicillin as the partner beta-lactam for daptomycin, is really kind of the way to approach these types of infections. And to kind of understand why we are talking about this particular combination as opposed to others, is to kind of bring in something that we call the seesaw effect. And so this is a particular effect, and we call it the seesaw because we have, daptomycin on the one side and ampicillin or their beta-lactam on the other. And as we see changes in the susceptibility to one or the other go up, we see this kind of reciprocal drop. So we're kind of trying to do a checkmate where we put it in one particular area and we say, well, if you're going to be resistant beta-lactams, we're going to hit you with the daptomycin, or vice versa, to really try to make sure that we have a bactericidal therapy. And so the caveats to all of that is that it is somewhat strain specific. And from what we do know from looking at the genomics of it, that this particular seesaw effect really seems to be dependent upon a particular stress response system called the LIA-FSR system. And so not to get into too much of the weeds on it, but really the kind of thing to think about is that this system turns on and signals to the cell that it's under stress when seeing daptomycin or certain other types of antibiotics. And the LIA stands for lipid to interfering antibiotics. So that kind of gives you an idea of some of the spectrum of which antibiotics would activate the system. But once you kind of get that stress going, it's going to make the cell change downstream and start expressing the phenotype to help provide protection from the antibiotic. And I think that if you look at the genomic studies and from what we know, the mutations that we see most commonly in most of our clinical isolates that are associated with daptomycin resistance are going to be a couple of mutations either in the LIA-F gene or in the LIA-S gene. And so I think if we're playing the odds, that most likely we're going to have a strain that, if it's going to have resistance or tolerance for daptomycin, that we're probably going to be seeing something along the lines of the LIFSR system. Now, to go back to your point about it being strain specific, we do know there are certain other mutations, particularly in a different cell wall stress response, the WALKR or YYCFG, that may not show this same kind of seesaw effect, and we may not get the bonus of the synergy there, while it still may provide some resistance to daptomycin. So again, there's those caveats. So I think that we need to be careful about what we're doing. But I think as long as you're paying attention to the dose of daptomycin that you're using, and I think really this kind of advocates, and this is going to be something that I'm saying without as much data, or maybe only kind of in vitro data, but I think using the combination up front, especially before we've had exposure to daptomycin, rather than as a salvage therapy, may give us better benefit, because we may not have those resistance mutations emerge as of yet. So we may catch it in more of its quote unquote wild type state. And at least from some of the simulated endocardial vegetation models and some of these others, we know that when you use a higher dose of daptomycin, it seems to prevent treatment emergent resistance, and using a beta-lactam, especially things like ampicillin, may also help with that. And so it kind of is a way to try to prevent yourself from getting into a worse place kind of from the beginning, is to think, if I know that I have an immune-compromised patient, I know I'm not going to really be able to count on their innate immune response and everything to come in and help too. Maybe think about, going strong up front, and then obviously we want to think about stewardship and all those other things, peeling off and stepping back if we can once we, have control of the infection.
So what usually happens sometimes, and I've been getting this call, that this patient is not responding to the combination, and again, the many factors this. So I tend to go to a third agent, particularly in these patients that are immunocompromised, for example, neutropenic, which maybe enterococcal domination is an issue. The third agent becomes either one of the new glycocyclines, starting with tigecycline, and I usually try to ask the lab to test for orithavancin, because we know that and that's coming back on this. And I have found that using tigecycline, particularly due to the pharmacokinetics in the abdomen, and that seems to be that triple combination in the more recalcitrant cases, a very interesting and anecdotically effective combination. So, Kerry, so what do you think about that approach?
Yeah, it's very interesting. I process the data with tigecycline. I do like the minocyclines, or the tetracyclines. C. diff is a problem. It's a problem here in Rhode Island. So anything we can do to decrease any C. diff outbreaks or spread is good. So my brain goes there first, even though it's slightly distracting from this. Tigecycline by itself, we know it's bactericidal, static, it's broad spectrum. I think there was a study or two out there looking at tigecycline use with VRE, and because of the toxicity, there weren't good data and it wasn't recommended. And I'm wondering if it goes back, as I recall this study, I like what you said about high GI concentrations. It has that good volume of distribution, but really low concentrations in the bloodstream. So if your patient's septic, as most of this audience knows, a typical MIC, say it's 0.125, but we get 0.0625 concentrations of tigecycline in the bloodstream. So that really distracts a little bit from use in a septic patient. But I do like that idea, and exactly what you said about use in the GI tract.
Yeah, and just to clarify, we never use that alone. And I'm talking about adding tigecycline as a third agent when daptomycin, ampicillin, seems to be, not clearing yet, and adding a third agent that there's some spontaneous data in combination of daptotigecycline endocarditis and also CNS infection that seems to work against. This is just anecdotal case report, but this is a step down, and probably could also be extrapolated to the new tetracyclines or glycocyclines, including omadacyclines, Dr. Murray has a recent data in the animal model that that may have a good activity in vitro. So, and then there's the issue of the oritavancin. Remember, this is a derivative of a glycopeptide, that is a long-acting that has activity against VRE, although resistant can be selected for. So I probably don't think that this will be a good thing to use in alone. We actually use it in an endocarditis patient, and there's one reported in literature as an add-on, and then due to toxicities, the patient ended up, being treated almost with oritavancin. Figuring out the pharmacokinetics, if it's, weekly or every 2 days, I think Kerry will teach us that, and that's not easy to see, but that's a step down and have all those ready. And of course, you eventually will have the aminoglycoside, if possible, and all that in at hand. So that stepwise approach, I think, allows us to try to minimize toxicities, and you do targeted therapy on this. So, Will, what do you think about the use of tigecycline or minocycline or eventually eravacycline in these patients?
Yeah, so I think that from at least the in vitro data that we have, which is a checkerboard where they kind of put the different concentrations on a grid and look more time kill assays, there does seem to be synergy between daptomycin and tigecycline. And then I think there was one wound infection model in a mouse that showed some efficacy of this combination against VRE. So potentially, we do have some in vitro data that it would be at least theoretically active in the patient, and then kind of as our add-on agent to the daptomycin and ampicillin, given the fact that potentially we're getting excretion into the GI tract, and are we able to theoretically maybe clear out a bit of some of this gastrointestinal colonization and try to eliminate one potential source from where these bacteremias are potentially coming from. So certainly I think that they potentially have a role in combination with other agents as an agent for treatment of these infections.
So we're getting to the end of the program, Kerry. So what are the final thoughts? This is a lot of interesting, opinions right now, but the clinical data supporting most of the things we've said is also absent. So what do you think the future should look like?
Oh boy. Well, what I'm thinking here is the next paper is the heck with combo therapy. Triple therapy is the future, right? Lots of research to be done there. As I said before, at the end of the day, what I absolutely love about infectious diseases, my passion is that it's so gray. And the downside, we don't have a lot of randomized clinical control trials, but we go to our in vitro data, as all of us do, and we play around with checkerboard, and we play around with time kill and flow models to try and get as close as we can to the truth and what to do with these patients. But Enterococcus is a tough bug. It's resistant, it's tolerant, associated with high morbidity and mortality. And let me say plainly, you have to throw stewardship out the window in these really sick patients. They're going to not make it till Friday. So we have to do everything we can. What I love hearing is that we need to be aggressive up front, maybe with a combination therapy, bring that inocula down in these serious infections, be safe, be aggressive, and do everything we can to save the lives of these patients.
Fantastic. Will, final thoughts?
So, I think that really a lot of times we're operating where we don't have the kind of data that we would like to be able to make these decisions. So I think one is to try to do the trials, even if they're tough, and to try to get information. And then we know that we have so many other things going on in these patients that get these infections that can impact the way that our clinical trials work. So I think then it really does come back to the bench and to say, what are the mechanisms that underlie this? And so why are the bugs becoming resistant, and why do they do what they do? Because if we can understand that, we can rationally design and form the trials that one need to be done, or two, which agents that we need to kind of select and how to employ them to attack these bugs. And so really that's kind of something that we'll kind of need to put forward, is just, to learn more about it so that we can make the best decisions that we can at the bedside.
Fascinating conversation, topic very close to my heart. We could spend the whole day and a whole podcast all day talking about this. So many things to investigate, so many things to research. So I welcome people to get into the field and try to find out how these superbugs work. So thank you very much for your participation. This is Cesar Arias, Editor-in-Chief of Antimicrobial Agents and Chemotherapy, signing off.